Good evening, dear friends. You know what is the best session that I read in today's agenda, which was at 6:30. My brain disk is full, man. I want a break, and that's the happy hour. I think it's just 30 minutes from now, and then we have 3 or 4 lectures. Probably. I think 3 lectures henceforth. So I'll try to be as brief and as quick as possible to cover this topic, targeting triglyceride, which may not be so relevant in the Western population, but which is extremely relevant in our Indian population. Now, in fact, targeting lipids was a question with a lot of skepticism. I started my medical education in mid-70s, and then that was the time this Compatin and then subsequently Mevastatin was coming in. And then there was a lot of skepticism about this lipids, whether they should be treated or not. In fact, there was a cartoon of this kind, that this is the group of people in the graveyard who received statin and who did not die of heart ailment. And these are the people who took statin and they died of either gallstones or cancer and so on and so forth. So statins and then the lipid therapy has no meaning. That is, I think, what was thought of during those days. But then obviously, as the time progressed, the statins proved, and then they have still remained number one. And now probably PCSK will be the only molecule which will supersede, but otherwise statins is the number one molecule. And it was not until 1994, till 4S, the simvastatin trial came, and after which you can see there was a very rapid decline with increasing use of statin. So this is what mid-70s with after Akira Endo's Nobel Prize, and then subsequently all the statins came in. And then all throughout, there was constant statin-centric treatment for LDL cholesterol, just one molecule. And then there was hardly any emphasis about the other parts of the lipids. And then this is what was seen, that all right, I mean, the statins are reducing the death rate, and then with 30%, 35% in different scenarios. But then again, if you see that when there is a 30% reduction in the death rate, there is still 70% residual risk. So how to tackle that? And then for that, it was thought that, all right, I mean, we have to see that the statins, no doubt that they're reducing the death rate, but do we have other parts of the lipid which if we treat, then they will offer the benefit? And then triglyceride was obviously the second important target which was thought of. But then again, the skepticism came about treating triglycerides, because triglyceride and chylomicron is a very big molecule. And during those days, it was thought about this LDL particle gets imbibed or translates across the endothelium. And then chylomicron is such a big molecule that it will never cross. So how chylomicron can actually produce, or these large buoyant molecules can produce any problem? But then subsequently, of course, now we know quite a lot about degradation of chylomicron, the intermediate lipoprotein, which we'll discuss subsequently, the remnant lipoprotein, and which produce these pathobiological mechanisms. So this initial skepticism of good, bad, and ugly, the good was HDL, the bad was LDL, and then triglyceride is just ugly big molecule but harmless, but that has changed, and with this remnant triglyceride, now there is a lot of evidence that it should be treated, and which is what we are going to discuss today in treating while targeting triglyceride. Now this is a meta-analysis of 17 trials with a large number of cases, and it was seen that with, especially in women, treating triglyceride is extremely useful. And then also, of course, in men as well, that there is 32% relative risk reduction in the event rate and 76% in women, with just one millimole reduction in the triglyceride. 1 millimole is 88 point something, so 89 milligram percent reduction. And then that was obviously, this was for the 76% and 32% was unadjusted. But even if you adjust it for HDL cholesterol, then also it was significant difference with good p-value less than 0.05 value. If you see the different tertiles of LDL cholesterol, this even up to 50, which Brian was talking about by using PCSK9, then even in this, all these tertiles of LDL cholesterol, you will find that as the triglyceride is increasing, then there is an increase in the event rate. So even with the least best LDL reduction, still reduction in the triglyceride is going to be useful. That is what it meant. This is another meta-analysis of 61 studies, and in which if you compare this 90 to 150, 150 we consider as a referent risk. So if you go above 200 and versus if you consider the optimal, then there is 25% risk reduction in the CV death and 20% risk reduction in the all-cause mortality. Quite good reduction. This is another meta-analysis of 29 studies. And then again, here the lowest tertiary and upper tertiary, this less than 120 versus more than 180 triglyceride. And then there was 72% overall risk reduction by achieving cholesterol. Even the most talked about trials for secondary prevention, the HPS lipid care, these are the, and 4S. Even in these trials, if you see the people who achieved LDL at goal, but then who had higher triglyceride. For example, here the low triglyceride and high triglyceride, the high triglyceride in the blue. So here again in both these trials, secondary trials, you will see that there is an increased event rate if the triglyceride is not controlled. That was about the secondary prevention. In the post-acute coronary syndrome, the PROVE-TIMI 22, again here you will find that those people with this less than 150 and more than 150 triglyceride, if the triglyceride is not controlled, there's 41% higher risk of not treating triglyceride. So that was for the acute coronary syndrome, the another group. So this is that PROVE-TIMI 22, whether it is cholesterol is controlled or not controlled, at goal or not at goal. In both this, there is a gradient with this triglyceride rise. Now this is the people who have undergone angioplasty, the undergoing PCI, and then high triglyceride and the event-free survival. If you see the less than 150 and more than 150 being the optimal figure, again there is a separation of the Kaplan-Meier curve as you can see here. Now this is from the Copenhagen City Heart and then Copenhagen General Population Study, and then the risk of myocardial infarction that was seen that as the non-fasting or even fasting triglyceride goes on increasing, then the hazard ratio of myocardial infarction goes on increasing, especially with more than 2 point, then there is a plateauing after 4, less steep rise after 4 millimoles. These are the various pathobiological mechanisms through which the triglyceride are expected to produce this. We will not go into the details for the brevity of time. And whenever the triglyceride is more, then as you can see here, that its main function is to provide energy and to provide in this mitochondria to go through the Krebs to the beta oxidation and then ATP generation. But at the same time, this when it is modified and then when it undergoes the remnant particle, the LDL and oxidized LDL, it will produce a foam cell and then it will produce the atherosclerotic event. So basically, it's not only LDL to which we have to center our attention, focus our attention, but even the intermediate density lipoprotein and then the VLDL chylomicron, all of them they constitute this ApoB containing or non-HDL cholesterol, and which is important. As you can very clearly see in multiple trials, it has been shown that in fact non-HDL cholesterol is even superior to LDL and or HDL upon total cholesterol upon HDL ratio. As you can see here, the Framingham study, the non-HDL cholesterol is superior. And then especially at higher values, that there is no gradient between this LDL, but then there is a progressive gradient with increasing triglyceride. Now this is a slide which is showing what happens with increased chylomicron. We said that chylomicron is just an ugly big molecule which doesn't go across the endothelium and doesn't go into the plaque. But then what it really does is it through this HDL interaction between HDL and LDL, it gives triglyceride. Basically, chylomicrons are to deliver triglyceride and energy to various tissue, whether it is adipose tissue, whether it is muscle tissue, and so on and so forth. So it just gives on donating triglyceride here and there. So it gives triglyceride to both, and then in exchange with this CETP, it exchanges for cholesterol. And then this LDL becomes a small dense LDL, which is all of us know that which is more pathological for atherosclerotic process. And similarly, the HDL, when after this exchange, becomes a small dense HDL, which is very easily excreted through urine. And then that's why we get very typically in these people that low HDL, and then these are the people with this conglomeration of this, these three things. And then all of us know that this small dense LDL particle, for the same amount of LDL concentration of 130, for example, here this person, that there is more ApoB, there are more particles, more ApoB, and then in inter-heart study there was very clearly seen that ApoB is correlated with increase in the myocardial infarction rate. And apart from that, of course, it provides it gives free fatty acids, and that can lead to the steatosis in the fat deposition in the liver, then steatohepatitis, then cirrhosis, and then ultimately the carcinoma of the liver also with all these inflammatory cytokines. Similarly, pancreatitis, alcohol and gallstone being the first two causes, but the third biggest cause for pancreatitis is high triglyceride when it is exceeding 500 or even 1000 milligram, especially when they take either alcohol or the ladies start taking the estrogen, the birth control pill, so on and so forth. Now in this ACC 18, there was a very good lecture, very good speech by this Abdullah Majumdar from Bangladesh. And then he spoke nicely about this ethnicity, and then this, he covered everything, including Filipino, Japanese, Koreans, Singapore, Malaysia, India, Bangladesh, Pakistan, and so all these countries. And this ethnicity does make a difference. For example, I mean, if you consider a Western person and an Indian person, both will have the same body mass index, 22, apparently normal looking. But then if you see the body fat, the central body fat, the Indian will have 21%, as opposed to that the Westerner will have less. And then as you can see here, as the body mass index is increasing, then 42% versus in this less body mass index, 17% will have triglyceride more, so which is 2.5 times more. So this is one peculiarity of our Indian population. Second is, of course, India is diabetic capital in the entire world, and in diabetes, especially if it is under control or poorly controlled, you can clearly see that there is this conglomeration of increased triglyceride and reduced HDL. So also with controlled also, in both the subsets, you will find that. And then this is related to the insulin, hyperinsulinemia, insulin resistance, as you can see the scattered the diagram here with this very linear relationship in the metabolic syndrome with dysmetabolic syndrome, what is happening. South Asia is just a small part, in fact, just the 3.5% of the world's territory, but it constitutes 1/4 of the world's population, 1.7 billion. So I think this is not a small population which can be ignored, and then unfortunately, this is not covered in the Western literature with a lot of neglect towards this triglyceride. And then in fact, in our population, this is what we see, that cholesterol, LDL cholesterol is not so high, but then triglyceride is high and then HDL is low. As that was in Bangladesh, this Majumdar's presentation, and then so also in our Indian 20th Annual Convention of American Association of Indian Physicians, they had this data about the Indians in America, and then as well as from our Indian also the same experience, that high triglyceride, low HDL, and high lipoprotein is a typical, what NAS say that deadly lipid tetrad, which we are facing. So the first, of course, is the cause, why we are having this, the faulty diet, no physical activity, and then thripty gene, and then there are various other genetic predisposition mechanisms also. And then which leads to this particular difference in this statin efficacy. As we can see here, the main study with statin in these various trials is showing good relative risk reduction, but whenever they have a subgroup with high triglyceride, the benefit becomes less. And then which we saw earlier in Pruvit-Timi 22 and then various trials. So basically, so far what I have emphasized is triglyceride is an important risk factor, and statin alone is not covering that. Now, what will happen if we treat the statin, if we treat triglyceride with various drugs like fibrate or omega fatty acid? So there are different trials, and then they were failure. Now, field trial was a very big trial in diabetic people with almost 10,000 people, more than 9,500 people, and then which was supposed to be a failed trial. But then look at this, the triglyceride was just 155, the baseline mean, and inclusion was just triglyceride more than 88, they had considered high triglyceride, and that was included. And then that's why there was not much difference in this event rate. But then the moment if you see the triglyceride, if you increase to more than 200, then there was 27% risk reduction. And then even if you correct it For LDL, or if you don't correct, sorry, HDL and no correction, still there is 27 or 23% further benefit by reducing triglyceride. Accord trial was another trial, which was again a negative trial, supposed to be a negative trial for fibrate. Again, diabetic people, half the size of field, 5,500 people. But again here, the baseline lipid, the mean was 162 only. And then again in this trial, the difference you will find that there was not much with the p-value of 0.032. But then if you again go for this less than, the triglyceride more than 204, and then plus low HDL, there is 31% benefit. And then these are the various trials, again showing this subgroup benefit. And as the main trials had not shown the benefit, which were taken into consideration by these various authorities, and then as opposed to that, the typical Indian scenario or our South Asian scenario where we have high triglyceride, we are expected to have benefit. And then this is how the graph, again a very linear, just like LDL cholesterol, what we have been seeing with this, there is a very linear reduction in the event rate. So similarly here also we can see here that for 1 millimole reduction in the triglyceride, that is 88 milligram percent of triglyceride reduction, there is 54% major CVD reduction. This is a DIAS trial, the diabetic atherosclerosis intervention trial. And in this, after doing intervention, this was simple angiography trial. And then in this particular trial, they had seen the stenosis and minimal vessel diameter in the follow-up study. And again, as you can see here, by treating triglyceride, it was giving benefit. We'll not go through the details of this, how VLDL produces these various pathobiological mechanisms. We have just seen that there is enough clinical data to convince ourselves that triglyceride is important. Although triglyceride doesn't enter the subendothelial lesion and the plaque, but then it produces its ill effects to this triglyceride remnants, as you can see here, that there is increased CVD with LDL, increased CVD with chylomicron, and pancreatitis with chylomicron. But with this triglyceride remnants, then this CVD is goes much higher. And this again, the Copenhagen study is a very clear-cut study which showed this particular evidence with this remnant cholesterol producing this marked effect. As the non-fasting triglyceride is increasing, this remnant lipoprotein is increasing. And this LDL cholesterol, no doubt it has got linear relationship and increase in the myocardial infarction rate. But this with this 90,000 population in the Copenhagen general population, as well as Copenhagen city heart study, with this more than 90,000 population, almost a lack of population. Here, with this remnant cholesterol, there was almost equal or maybe little steeper Kaplan-Meier curve for the event rate. There is one more thing in Indian population, what is called as the genetic problem with this ApoC3. And ApoC3 is, what is ApoC3? ApoC3 covers this VLDL particle and which resists its lipase action and is lysis by lipoprotein lipase. And then the moment it resists, then the VLDL goes on increasing and those remnants and intermediate lipoproteins go on increasing. And then apart from that, ApoC also has got various other ill effects like endothelial and VCAM and then adhesion molecules and so on and so forth, which increase this atherosclerotic, the acute coronary events or strokes. Now, management of hypertriglyceride patients. This currently, of course, these are the subgroups in which we should divide, and then more than 200 we should definitely treat. That is what the various guidelines have shown. And when we treat, I don't mean that jump on the fibrates or some medicine. First go for, of course, the lifestyle modification in all the guidelines is number one. And then all this, the material which increases this fat, the contents of the diet which increase triglyceride, they should be given the first preference. And after that, the go next for the secondary causes of this hypertriglyceridemia. Eliminate all those causes, like increasing this very heavy fruit content, the fructose and glucose, and these certain drugs which our non-selective beta blockers are not commonly used, beta blockers, thiazide diuretics, estrogen, tamoxifen. So, and then all these drugs, various illnesses, so all those things should be ruled out. And then after that, when it is primary hypertriglyceridemia, then we have to go for triglyceride reducing medication. And of course, fenofibrate becomes number one, which reduces triglyceride to the tune of almost about 40–50%. Omega-3 fatty acids, niacin, statin, they also reduce it. But first two are generally considered more. About fibrates, we have already covered 3–4 trials. So a few words about this omega fatty acid. So omega fatty acid, this icosa and pentaenoic docosine icosa pentaenoic acid. So they make this ApoC3 less, and so obviously the lipoprotein lipase can degrade this particle, and then the triglyceride reduces. And then these are the various trials, especially this omega-3 trial, the GC, Origin, and JELIS. JELIS was a Japanese, mostly primary prevention. GC was after the post-myocardial infarction. And there was good reduction, almost 26% relative risk reduction in sudden cardiac death in GC trial. But just one thing I want to highlight, that this for triglyceride reduction, we really need a good dose of omega-3 fatty acid, like at least 2 grams. And then some of the trials have used even this 4 gram and 6 gram, etc. But then for post-myocardial infarction, this 1 gram is sufficient. Unfortunately, our tablets which we get in India, majority of them are just 300, 150, 300. So we have to give multiple tablets. But then this is the minimum dose which we should give to get the benefit. This reduced its strength are the ongoing trials. This is another trial also. This is because omega-3 fatty acids are unpalatable, they give fishy odor, and then they are very big. So there is some effort made to make the synthetic, this omega-3 fatty acid, and then synthetic EPA derivative, and then this is icosapentide. And then this is very simple, once a day, and then regardless of food intake can be given anytime, and these trials are on the way. These are, of course, the novel molecules. Just to complete today's lecture, I'm just covering them. This ApoC3, that the antisense is being tried in the animal experiment, rodent. It has been shown to be effective. And then, as you can see here, antisense, or this, the radionuclide or genetic manipulation, we can get the reduction in the triglyceride. We can get reduction in this various event rate. And then these are the various other molecules also, which are again being tried in this various multiple phase 1, phase 2, and nothing has reached the phase 3 trial as such. This transfer protein, this microsomal, this is another molecule which reduces all this. So these are just the trials which are going, and then in the phase 1, phase 2 we will not cover. So last, I think 3-4 slides about the guideline. So are we yet to include them in our use in the guidelines? So yes, in the European guidelines is 2016, the ESC and then European Association, this thing, Atherosclerotic Society, it is included in the secondary, as a secondary this goal for non-HDL, ApoB. Then in endocrinology guidelines in the American Endocrinology Society 2017, again for secondary target, non-HDL is included. In American Diabetic Association 2017, statin and fibrate co-administration, the combination therapy is especially considered in men with triglyceride more than 204 and HDL less than 34. This is ATP3 recommendation for this 200 plus as a secondary goal, and 500 plus, of course, to prevent this pancreatitis. And then our Lipid Association of India, this is LIA. And then again, it again emphasizes that we Indians have this peculiar lipid tetrad, and then it is important, and then it should be considered even as a primary goal. So this is my last slide, in which I've just covered that the epidemiologically, this statin was initially at a standstill with a lot of skepticism. Post-4S study after 94, there was a tremendous gain, and now it has come to again a little plateau phase, and then again there will be another PCSK9 phase here. The HDL was thought to be very, HDL-centric treatment was thought to be extremely useful, but then again after 2005, 6, 7, after Illuminate, Illustrate, and the great fall of this torcetrapib and then various other CETP inhibitors, it has fallen down. And now there is a gradual increase in the awareness and then acceptance of triglyceride-based treatment to reduce triglyceride remnants and then produce this various event rate which I have discussed so far. Thank you very much indeed for a very patient hearing. Thank you.
Thanks, Raju, for that excellent, exhaustive review about triglycerides. He wants to know what saroglitas are. Saroglitas are.
Yes, actually, fenofibrate is the molecule that I discussed, which is a PPAR alpha. Yes, PPAR alpha. Right? Yeah. So now we have this PPAR alpha and PPAR gamma, this entire spectrum. Now on one side there is rosiglitazone, And then on the other side, there is fenofibrate. And saroglitazole is in between, so which has a mixed action for diabetes as well as for reduction in the triglyceride. So it is expected, and theoretically, it is expected to be very good in reducing diabetes, HbA1c, as well as in reducing triglyceride. But only skepticism is we don't have any international good quality trials so far. Because what happens in India, most of the time the trials are conducted by the pharmaceutical companies themselves. And then the filter level is at the pharmaceutical companies level. I think Dr. Ponde knows very well that when S-amlodipine was being done, then he had a result that S-amlodipine produces edema. Somebody else had shown that S-amlodipine doesn't produce edema. And in Cochin, there was another result that it was neutral. So you were eliminated from the subsequent national presentation. The Cochin was eliminated, and only Pune was favored for all the national presentation. So it so happens that in India, that when the company, the pharmaceutical company who manufactures the drug itself is conducting the trial, the filter level is at the pharmaceutical company. So I think so far, theoretically, this saroglitazole molecule is good, expected to produce both benefits in diabetic as well as with high triglyceride group. But then for the evidence, if you see the scientifically clear-cut evidence, I would say that I would still wait for a while before I make my final comments.